patient and encouraging our teaching students. We have 5 fairly and encouraging our teaching students. We have 5 connection briefly. We lost the Zoom connection briefly. I hope we are back on now. Dr. Obijit Datta, if you would say a few words before we start.
Hello.
Hi, Obijit Datta.
Good afternoon, everybody, and Shubho Vijaya to all. Since this is after our Durga Puja, we are having some interesting cases which we are eager to hear from you. Now I hand over the mic to Dr. Sushmita Banerjee and the moderator to conduct the proceedings.
Thank you. I would now like to ask Dr. Shogata Acharya to start the proceedings and introduce the moderators.
Thank you, Sushmita. On behalf of our department, I welcome you all in this clinical meeting. As Sushmita has already mentioned, we have got 5 cases. So let us, without wasting much time, let us start the meeting. Dr. Indroni Kormukar will moderate the meeting. He is one for senior registrars. So I hand it over to Dr. Indroni to continue with the meeting. Indroni.
Thank you, sir. Good afternoon, everyone. Our VGTs will be presenting some interesting cases which were managed in our department in last 12 months. So, without wasting much time, we will be moving forward to our case presentation. Our first case presentation, Listen to Your Heart by Dr. Ognivo Dev.
Good afternoon, my respected teachers, my fellow presenters and the audience. My topic is Listen to Your Heart, and it involves Master E, a 1 month, 14 days old male patient who presented to our institution with complaint of high-grade fever for 2 weeks. Significant past history included that he was a late preterm child of 36 weeks. He was low birth weight of 2.4 kg weight and born by normal vaginal delivery in an outside institution. The baby cried after 2 minutes of Bagmas ventilation and required an ICU stay. When we examined the baby, we found that he had a temperature of 99.8 degrees Fahrenheit. His cry response and activity was good. He had a pulse rate of 138 per minute and respiratory rate of 38 per minute, maintaining saturation of 100% in room air, had no pallor, cyanosis, clubbing, jaundice, or edema, and no malformation or dysmorphic features could be seen. When we examined the chest, we found bilateral vesicular bed sounds present. S1 and S2 heart sounds were audible. And on para-abdomen examination, it was soft and IPS was present, and CNS examination was within normal limits. Blood investigations revealed that he had a hemoglobin of 8.9, whole WBC count of 17,700 with neutrophil of 7 and lymphocytes of 70, platelets of 3.2 lakhs, PCV of 28.1. His CRP was negative. His coagulation profile, liver function test, kidney function test, and electrolytes were in normal limits. Malarial parasites, dengue and S1 antigen, dengue IgM, and S type IgM were non-reactive. Blood culture revealed no growth. Urine routine examination was within normal limits, and urine culture also revealed no growth. So we did all the first-line investigations, and all the results were more or less inconclusive. Hence, next we decided to perform a 2D echo. This is a 2D echo of the child. This is the right atrium, this is the right ventricle, this is the left atrium, and this is the left ventricle. We can see that a large mass or vegetation can be seen hanging from the interatrial septum into the right atrium and through the tricuspid valve plunging into the right ventricle. The mass was very large in size, about 19 millimeter into 6 millimeter. When we did M mode, we can see that there was no appreciable obstruction or regurgitation, and there was good biventricular systolic flow. This put us into a dilemma as to how such a large mass or vegetation was present in this small kid. Hence, we decided to take elaborate history. When we took history from the father, we came to know that when the baby was in the NICU at first during birth, he had umbilical venous catheterization done. It remained in situ for 15 days during the NICU stay, the period during which he received antibiotics. Thus, we came to a provisional diagnosis that this could be a case of catheter-associated bloodstream infection leading to infective endocarditis. So, we decided to manage the patient by surgically removing the vegetation. Removal of vegetation by catheter was not possible due to the following reasons. Firstly, the vegetation was crossing the tricuspid valve, and snaring via the valve could have damaged it. Secondly, risk of dislodgement of vegetation could have caused massive pulmonary embolism. Now let us see the course of the baby in the hospital. At first, the baby received injection piperacillin, tazobactam, and gentamicin for 1 week preoperatively. Then the vegetation was removed surgically by putting the baby on cardiopulmonary bypass. The postoperative days were stormy due to fluctuating blood pressure and third spacing. As the urine output was less, peritoneal dialysis was started on first postoperative day and continued till third postoperative day. On third postoperative day, there was also upward rolling of eyeballs, so syrup levetiracetam was added. Next, on fourth postoperative day, increased opacity was noticed in the right upper lobe in X-ray, and we had suspicion of ventilator-associated pneumonia. On the sixth postoperative day, the patient was extubated to nasal CPAP. The CPAP was intermittently continued with physiotherapy till 11th postoperative day. The drains were removed on the 6th and pacing wires on the 12th postoperative day. Finally, the baby was discharged in a stable condition on the 13th postoperative day. This is the pre-discharge 2D echo of the child. Here, this is the right atrium, this is the right ventricle, this is the left atrium, and this is the left ventricle. We can see a small stump at the interatrial septum. There is no vegetation as it had been surgically removed, and this is nothing but the stitch that had been put in that place after removing the mass. There is good biventricular systolic flow, and no pleural and pericardial effusion could be seen. When we did a biopsy of that vegetation, we could see dead necrotic tissue and no growth could be seen. These are some related case reports. Firstly, a 4.5-month-old infant with transposition of red vessels and large VSD developed acute infective endocarditis following cardiac catheterization. The next case shows that endocarditis, both infected and non-bacterial, detected at autopsy in 10 patients in the course of 1 year from an NICU. In 8 out of the 10 patients, the umbilical venous catheter was documented to lie within the heart. And the lesions were mainly in the right heart, a distribution which contributed to the usual site of catheteristic misplacement. Therefore, one can conclude that endocarditis in these neonates is a result, maybe a result of endocardial injury due to misplacement of the umbilical venous catheter. Finally, to sum up, infective endocarditis is rare in neonates and children. Rapid echo diagnosis and advancements in treatment have led to a significant reduction in mortality in developed countries, but in our countries, developing countries, this mortality still remains high. To diagnose infective endocarditis, a high index of suspicion is necessary, especially where a central venous cannula or other risk factor is present, and extensive investigations are required to detect any associated complications. Echo should be done in NICU graduates with UVC or invasive lines. Endocarditis can occur in neonates as a result of endocardial injury caused by umbilical venous catheter or other catheter misplacement. The ideal placement of UVC should be in the IVC right atrium junction to avoid intracardiac trauma. The lesion is potentially serious, but if the venous catheter is placed correctly, it is almost certainly and entirely avoidable.
Thank you, Amigo. I will now invite queries from our respected judges and audience.
So my first question, what made you think of doing an echo routine? Was it, or did you find anything wrong with the heart clinically?
Or I would like to say that what are the clinical pointers you got? What are the clinical pointers from your clinical features and history you had got? And what are the lab pointers you got to make a diagnosis that we have to go for an echo?
I showed that at first nothing was significantly found. We only found that he had high fever.
Yes.
And blood investigation showed that he had high WBC counts.
And absolute neutrophil count was very low, if I remember.
Yes, yes, ma'am. So maybe it can be that.
How much was the absolute neutrophil count?
17,070, I calculated, around less than 1,500 something.
Yes, ma'am.
Okay, relatively
So
less.
it may be a case that it may not be a case of bacterial endocarditis, maybe fungal or any other, but our blood cultures reveal no growth. So we are exactly not sure. Maybe it was due to the case that during his NICU stay, the baby received antibiotics and other medication, and the culture came negative when we did in our institution. That may be.
How long ago the baby was discharged? It was only 6 weeks old.
Yes.
And he came with fever of 2 weeks.
Yes.
That was again a long newborn
Yes.
to have fever for 2 weeks.
Yes.
Long time.
So at first, when the baby was born in an outside institution, he remained in NICU for 14 days, and then he was discharged.
14 days, IVC catheter was there, you said?
Yes, after that he was discharged.
Immediately after.
Around that time, as per the history of the father.
What was the reason for the 14 days? Did they mention it?
No, ma'am. According to father and the documents we got, the baby had presumed sepsis. And so the channel was not could not be done easily. So
And what was the weight when the baby came here?
When the baby came here, his weight was around 3.2 kgs.
And the birth weight?
2.4. After he went home and he came back, he came with history of fever for 2 weeks when he came to our hospital. And at that duration when he came, his age was 1 month 14
It was
weeks.
all through high grade fever, or there was a low grade also? It was all through high grade?
They found only 99.8. So it was again,
And
fever was also not very.
According to history, that was
So normally in infection, when endocarditis, you get a little low grade, a
Yes.
long duration low grade. So it was. So what made you do the same question again? I'm going. What made you
Yes,
think
ma'am.
that we
At
will
first,
directly go for an echo?
we did the first line investigations, the fever profile, and it yielded no results. So we decided to think out of the box and do some other tests. And when we did that, this result came out.
It's a good early diagnosis. Otherwise, like.
Baby was put on dialysis itself,
Yes,
for low UV.
yes,
So how long it was done and
yes, sir. I told that on the first postoperative day, dialysis was started, peritoneal dialysis, and stopped on third postoperative. After that, it improved.
It was a little strange because there was no inflammatory marker. CRP was
That
not
was the thing, the
high.
CRP was.
White cell count, neutrophils were very low. So it's very, so
And you didn't, when you did one single culture only.
No. After that, that was the first investigation we did. I told that. After that, we did repeated cultures.
But then
every
you
one of
have
the,
already started antibiotics.
yes,
on the
ma'am.
newborn.
That
Before, once you got the culture report, you have already started antibiotics.
Yes.
So after that, you repeated the cultures.
What was the biopsy report? Was it infective at all, or it was just vegetation?
It was just vegetation, sir.
I think it
Fibrinous
was probably
necrotic.
not infective. I think it was probably.
Infective will be having at least the markers which should have been there, but
I think it was probably not infective. It was some sort of vegetation after, maybe it was sterile vegetation after
Maybe, sir.
all the.
Sterilization.
Thank you, respected judges.
Well, good case.
Now we will proceed to our next presentation, not originality but duplication, by Dr. Disha.
Good afternoon, everyone. I am Dr. Disha Parekh, final year DNB PGT. So my case goes like this. A preterm 31-week by gestation, male baby, twin one among a pair of dichorionic diamniotic twin conceived via in vitro fertilization, was delivered by emergency LSCS indicative of intermittent fetal bradycardia. After birth, baby had poor respiratory efforts and heart rate was less than 100 per minute. So baby required bag and mask ventilation for around 30 seconds. APGAR score was 6 at 1 minute and 7 at 5 minutes. Birth weight of baby was 1.76 kgs. After that, baby developed respiratory distress with significant intercostal and subcostal retractions and audible grunting with a Silverman-Anderson score of 7 out of 10. Baby was shifted to an ICU and treated with nasal CPAP. Further, chest X-ray was done, which revealed bilateral diffuse granular infiltrations and air bronchogram, following which natural surfactant was administered intratracheally at 4 ml per kg, and again baby was put on nasal CPAP. Following this treatment, baby improved gradually and was weaned off from CPAP over the next 48 hours and shifted to nasal bronch oxygen. Feeding was initiated with expressed breast milk on day 2 of life via NG tube. As the feeding was gradually being increased, baby developed a significant epigastric distension and started vomiting. At this time, baby had already passed meconium and intestinal peristaltic sounds could be auscultated. And also the sepsis screen sent previously was negative at this time. X-ray abdomen was done, which showed distended ball loops without any air fluid level or air under diaphragm, which was also confirmed by USG abdomen, which also showed gaseous distension of abdomen and presence of air bubbles in the small intestine. So this ruled out the possibility of gastric outlet obstruction. Here we considered the possibility of duodenal web. So to delineate the exact anatomy of upper GI tract, we planned the upper GI contrast study. Water-soluble gastrographin contrast study was done, which showed contrast material is filling inside the gastric lumen and spillage of contrast at the large cystic outpouching and visible wall loops. So here our differential diagnosis were gastric duplication or other enteric duplication and any cyst in pancreas or adrenal. Since the origin of cyst was still uncertain, so CT scan of whole abdomen was done, which showed that this large cystic outpouching at the right side of stomach communicating with the gastric lumen. So to summarize, we have got a 31-week preterm baby conceived via IVF pregnancy, first twin. After birth, baby required positive pressure ventilation for around 30 minutes, following which he had good spontaneous respiratory efforts and heart rate was more than 100 per minute. But due to respiratory distress, baby was put on nasal CPAP as the chest X-ray was suggestive of respiratory distress syndrome. Surfactant administration was done Success screen was negative. Gradually, baby was weaned off from CPAP and feeding was started. As the feeding was gradually increased, baby developed abdominal distension and X-ray abdomen revealed distended ball loops without any air fluid level or any gas under diaphragm. And USG also confirmed that gastrographin contrast study revealed contrast filled inside stomach and spilled at the large cystic outpouching. And origin of this cystic cavity was confirmed by CT scan. So as the baby was having progressive gastric distension and with our this provisional diagnosis, surgical resection was planned, exploratory laparotomy was done, and a large cyst was seen communicating with the stomach at the lesser curvature, which was being supplied by the right and left gastric arteries. The cyst was resected completely and a specimen was sent for histopathological analysis. As it can be seen in the picture, cyst communicating with the gastric lumen, rest of the wall loops are healthy. Cyst was completely resected and margins were opposed with stomach. Histopathology report revealed severely congested and edematous cyst wall, and that was lined by gastric foveolar epithelium and outer smooth muscle coat with muscularis propria and muscularis mucosae. So baby was kept nil per oral till postoperative day 6. On postoperative day 6, repeat contrast study was done to rule out any residual obstruction or any spillage of dye, which showed a smooth passage of contrast from gastric outlet to duodenum. Following which, nasogastric feeding was again restarted and gradually full feed established. Now on day 15, baby again developed lethargy and was having infrequent apnea. Symptoms were manifested with feed intolerance. At this time, again, sepsis screen was sent and which was found to be positive with raised CRP and raised total count. And so empirical antibiotics were started and blood culture grew Acinetobacter baumannii. So injection meropenem was continued for total of 14 days according to the culture and sensitivity report. CSF analysis was also done, which was negative. Following this, baby gradually improved, remained stable and discharged on day 37. So GI tract duplication is a rare congenital anomaly with an incidence of 1 in 4,500 births, while the gastric duplication being the more rare with the incidence of 17 in 1 lakh population. Features of GI obstruction like feed intolerance and epigastric distension are common in neonates, while in older children and adults, recurrent vomiting, abdominal pain, rectal bleeding, and other non-specific GI symptoms have been observed. 90% of gastric duplication cases occur along greater curvature and rest 5% is seen along lesser curvature. So in our case, it was seen along lesser curvature. Diagnostic criteria for gastric duplication are: cyst wall is to be contiguous with the gastric wall. Cyst is to be surrounded by a layer of smooth muscle which is continuous with the gastric muscle. Cyst and stomach should share a common blood supply, and cyst is lined by any type of epithelium of GI tract. And all these criteria were applicable in our case. 80% of gastric duplication cases are cystic or non-communicating type and 20% are tubular or communicating type. Ectopic tissues like duodenal, pancreatic and respiratory tissues can be present alongside the cystic mass. There is a significant risk of malignant transformation and adenocarcinoma being the most common, while neuroendocrine carcinoma and squamous cell carcinoma are also seen, though less frequently. Surgical resection of the entire cyst wall is the treatment of choice. So important points here are: gastric duplication is a rare congenital anomaly which should be suspected in neonates with features of gastrointestinal obstruction along with other more common pathologies. As there is a significant potential of future malignancy, early surgical resection of the entire cyst wall is the treatment of choice. Radiology can provide supportive evidence by confirming the presence of cystic mass at stomach, but histopathological examination of the resected specimen confirms the diagnosis. We have also reported this case to Indian pediatric case reports. Thank you.
Dr. Tisha. Now we will go for quick discussion.
How do you want to follow up this case?
Ma'am, any GI symptoms should not be there. And any malabsorption.
And you said that there's a chance of malignancy. If the full resection is not done, how do you assure full resection is done? So in that perspective, do you need to follow up the patient? How long you want to follow up? And how will you counsel the patient during discharge?
GI symptoms, and at that time we monitored the blood glucose regularly. For
That was
any,
during hospital. I'm talking of post-discharge. Do you feel this child needs routine monitoring or close monitoring? So what counseling you give the parents? And
on the routine follow-up, all these points will be examined and growth monitoring will be done.
so should you keep a concern of malignancy or not? That's the question to the audience, particularly the seniors who have diagnosed. And what are the rates of, did you find any come across this thing?
Because you are directly involved with the patient.
Yeah.
Ma'am, basically, all the previously case reports about the gastric complications, all of them reported with malignancy in an adult age group, mostly. And most of the reports are also with malignancy and the incidental finding of gastric duplication inside it or outside of the malignancy covering the gastric duplication or duplication. It was reported in the adult group. So, till now, there is no specific guideline for which date we need to, up to which date we must monitor the child or a neonate who is having a gastric duplication application. But we can do if there is any symptoms related to those like adenocarcinoma or pancreatic carcinoma or anything that develops. Any symptoms related to those, if develops in this child.
So ideally speaking, we have to tell the parents very carefully that you have to do a very thorough monitoring with us. Obviously, you cannot roam around across. So that is a very good important counseling we have to give this type of cases.
No, I mean, the question is, after dissection, is there still a chance of adenocarcinoma or not? I think that is the important
that is
question.
still there because
Once you remove it, is
If
there
the
still?
resection is not removed properly, that is
Complete
why the
removal we
entire
don't know.
resection, resection of the entire cyst is always recommended in this.
So whether the removal is complete or not, that nobody can say. So that is the only thing which is a follow-up. So whatever may be a follow-up is very important for this particular case.
My one question, I mean, what is the role of endoscopic, or is it too small babies, so endoscopy is probably not feasible? The role of endoscopy?
Or a CT scan was adequate to make a diagnosis.
CT scan is
Because giving
CT scan and
contrast-
MRI. These two things are basically
So
the
then we-
diagnostic of a duplication, entering duplication. But in a neonate, MRI is more hectic process or this thing. So CT scan is preferred.
Then we could have avoided the gastrograph in contrast.
Actually, first we were suspecting not a duplication. Firstly, we were suspecting it as a upper GI pathology with the obstructive etiology. So we need firstly we had opted for that.
So what was your diagnosis first? What you
Initial
found?
diagnosis was gastric obstruction.
Gastric outlet obstruction, failure gastric duodenal vein. Initially.
Regarding this CT and MRI, both are equally informative, but the parents opted for CT scan because of the financial issues. So that is why because they will give the similar information, both of them. So we thought that we'll go for CT scan if it is adequate. And because we have got all the information related to the pathology, so we didn't consider to do MRI.
Just to help your paper, those statistics which you have given, 1 in 5,000 and 1 in 1 lakh, like that, how many of those cases were twins? Means to me, it sounds very interesting that your case was one of the twin. And I'm quite sure those statistics which you are quoting, they are not twins. This is what I think. Though this is the first time I'm hearing such a case, you see. So I should say that you must emphasize that point next time when you present, and especially when you have printed your case, you see, you should have highlighted that point, that this is one of the twin and IVF twin. Both the points are very...
Actually, that was the point we highlighted during the publication.
Oh.
That, yes, because that is, we haven't seen any other reports in IVF pregnancy or IVF, because now IVF is still in an evolution phase.
That's right.
So we don't know what are the complications, what are the associations.
That's right.
Which is just maybe a chance finding, but we have reported this case and we have mentioned that this is an IVF patient.
And twin pregnancy, this is very important.
Yeah.
This is one of the twin. You see, this is
That was
important.
one of the main
And the
points
other
we mentioned.
So you must, next time when you present, this is very important thing you should emphasize.
Is there a genetic linkage? Because it was a dichorionic diamniotic anyway, but
Established.
Thank you, sir. We are moving forward to our next presentation. Veritas Vincit by Dr. Atreya Samanto.
So good afternoon, everyone. I am Dr. Atreya Samanto, DND PGT Department of Pediatrics. And today my case, Veritas Omnia Vincit, it actually is about a child named Master R, a 9-year, 2-month-old Hindu male child residing at Kolkata, who was presented at the CMRI emergency room with a history of snake bite in right leg at around 9:30 a.m. in the morning at the school toilet. So actually the incident went like this, that the boy went to the school toilet where he felt a sharp pain in his right leg. The child saw a black snake which was hanging from his leg. He then pulled it out with his both hands and threw it out. The boy was then rushed to the nearby rural hospital where he was treated with APS of 10 vials and injection hydrocortisone, and then he was referred to CMRI for further management. So on admission, we had found the child was afebrile, alert, oriented to time, place, and person. The vitals were stable, BP was 100/60, and saturation was 98% in air. And on systemic examination, the GCS was 15/15. There was no ptosis, no neurodeficit, no hematuria, petechia, or any bleeding manifestations. And also there was no abdominal tenderness. All other systems were apparently normal. On local examination of the right leg wound, we actually find 3 bite marks, which was most probably due to multiple bite attempts made by the snake. There was no swelling, but mild erythema and mild tenderness present. When the blood investigations came, we actually saw the hemoglobin level was 13 gram per dl, total count was 9,900, platelet was 2.3 lakhs, LFT, RFT, and coagulation profile was also normal, INR was only 1.05. And the urine report was also apparently normal with a clearly appearing urine and RBC of 1 to 2 per high power field and WBC of 1 to 2 per high power field. So we had actually admitted the child in PICU, proper monitoring was done. The WBC20 test was done at the admission was normal. The child remained hemodynamically stable. There was no further neurodeficit developed. There were no further bleeding manifestations developed. The WBC20 test, which was repeated after 24 hours, was also normal. No further AVS was given and the child was gradually discharged. So after this episode, actually 2 weeks after this episode, the child got readmitted with a passage of dark red urine. And similar episode happened to the child 2 days before the day of admission. This is the dark red urine sample which the parents brought from home. So we had actually promptly admitted the child at PICU, blood and urines were sent, diet fluids and prophylactic antibiotics were started as per unit protocol. And on examination, we found the child was afebrile, alert, conscious, heart rate was 86, respiratory rate was 22 per minute, blood pressure was 100/70, the chest and CVS examination was also normal, abdomen was also non-tender, the bite site actually showed no erythema, tenderness, or edema. There was no petechial spots, no neurodeficit, and GCS was also 15/15 this time. So we actually thought at that time that could it be a case of a delayed presentation of a hemotoxic snake bite? Hence, we did some literature review and we found that there were previously reported cases with delayed presentation of hemotoxic snake bite. A case of acute kidney injury was reported after 4 days of a snake bite. There was also another case report with a broad ligament hematoma, which occurred 2 days after viper bite. And even a case of hemothorax was reported 6 days after a viper bite. So it could be a delayed presentation of snake bite. The blood investigations report came and it showed that hemoglobin level was 12.2 gram per dl, total count was 8,700, platelet was 2.8 lakh, LFT was normal, and the coagulation profile was also normal this time. INR was 1.07 and urea was 22 and creatinine was 0.44. But with our surprise, we actually see that the urine routine and microscopy report showed that the appearance of the urine was clear. RBC was only 1 to 2 and WBC was also 1 to 2 per hypertrophy. So how could be this urine report in a child with a hematuria? So to unveil the mystery, we actually decided to send both the red urine, which was collected at home at microscopy, and also a separate urine sample we again collected from the at our hospital, and we sent that for microscopy. And the red urine, which was collected at home, sent for analysis, is actually showed a deep purple stain of the urethric strips. There was erroneous colorimetric values. There was no RBC or even no cells present. And the orthoptoridine test, which was done to detect blood in urine, it was also negative. Hence, we further sent that sample for biochemical analysis, and it actually showed presence of potassium permanganate. So, which is agent which is used to contain to make a deep purple color. And the urine which was collected at our hospital, which was sent for microscopy, was absolutely normal. So at that moment, we started to connect our dots. Firstly, the child gave the all history by himself. Secondly, 9 months. Nobody except the child had seen the snake which had bitten him, and the child never had a colored urine in front of others. And there were actually 3 bite marks at the first bite at first time when the child was admitted at the right leg of the child. So at that moment, we actually expressed our suspicion in front of the parents that the child might be fabricating his illness. And our provisional diagnosis at that moment actually had 2 differentials. Firstly, it could be a case of a factitious disorder. And secondly, it could be a case of a malingering. So we have to understand the difference between factitious disorder and malingering. So in factitious disorder, the patients consciously induce, feign, or exaggerate the physical or psychiatric symptoms for primary gain. There is no secondary gain. It's purely internal gain, such as a desire for attention or coping with stress or enjoyment in stumping healthcare workers. And there is 2 types as per DSM-5. Firstly, that the factitious disorder imposed on self, which was previously known as Munchausen syndrome. And secondly, factitious disorder imposed on another, that is previously known as Munchausen syndrome by proxy. Now, if we come to malingering, malingering is a falsification or profound exaggeration of illness, both physical or mental, to gain external benefits. And as per DSM-5, it is also not considered as a psychiatric illness. The secondary gain is necessary to differentiate malingering from factitious disorder. Malingering actually holds a poor compliance with treatment, and patients typically stops complaining about the illness only after gaining the external benefit. We also found some previous case reports. One case series was reported, children aged between 9 to 15 years, 4 with cases of factitious disorder and 2 was reported with malingering. All of the children were girls. And even in a 5-year-old boy, a case of malingering was reported from Wesley Guild Hospital, Nigeria. So in our child, we actually done a psychiatrist referral, proper psychiatric counseling was done, and the child confessed that he himself had put color in the water. And he actually noticed during his previous hospital stay that the doctors were asking the parents about reddish discoloration of urine. Hence, he noticed that. He pricked himself with a pen to make those bite marks. And the child actually done all these things and taken all this measure because he did not want to attend the school. He had basically school phobia. The parents were properly counseled about the condition of the child. So our final diagnosis of this case is a malingering, the psychiatric counseling of the child, and the behavioral therapy was advised. So what are the take-home messages we get in this case? Firstly, prevalence of psychiatric disorder in childhood is rising day by day. Especially school phobia and examination phobia have increased among children during this post-pandemic period. Proper diagnosis and proper counseling of both children and their parents are the major challenges. And behavioral therapy, pharmacotherapy, psychiatric counseling, and long-term follow-up are the mainstays of management. So finally, at the end of this case, we actually understood that veritas omnia vincit, that is, truth conquers all things. Thank you.
Thank you, Arjun. Now the session is open for discussion.
So the child could manage to come 2 times.
Yes, ma'am.
The first time we didn't see any findings like when we discharged the child. The first time when the child was admitted,
Yes.
post the anti-venom and all, so the child was admitted to have a follow-up to a higher
Ma'am,
center, or the
yes.
child was having complaints at that time.
No, ma'am. At that moment, they were treated at the rural hospital with AVS, and then they promptly referred to any higher center. So
Just
that
for a
time,
follow-up.
just for a follow-up. So we at that time we didn't found, and as a routine protocol, we had done the WBC 20 tests and all, and to look for the other. It could be both a hemotoxic and neurotoxic bite, but all those signs and symptoms which develops in actually neurotoxic or hemotoxic bite, they didn't develop. We thought it could be a non-venomous snake bite, and we discharged the child.
So very ectopic question I'd like to ask, like we are getting a child of 9 years. I would say the child is super intelligent, correct?
That is what I mentioned.
Super intelligent.
Because it
and-
was our question that when the child understood that hematuria or reddish discharge
That's what I was going to ask.
Super
Where did he get the idea?
during this previous admission, we actually, all of us consultants and the resident doctors all were asking the parents about is there is any reddish collection of urine, and he actually noticed that thing. That snake reddish urine, it occurs in
No,
case of
during
snake
the
bite.
first admission.
During the first admission.
No, during the first admission in rural place, you see, didn't they look at the bite mark?
Actually, that is
When he came to you,
in cases of venomous or any kind of snake bite, if multiple bite attempts done by the snake, then there could be multiple bite marks. So most probably,
Local redness, irritation, that should be there.
yes, ma'am, erythema was there, and mild
How
tenderness
we
was
managed
there.
to do the erythema with the pen mark?
Actually, what he told to us, he had pricked with the pen, so. Right.
There was no swelling happening.
Yeah, actually, when the child came in the emergency, he was first seen.
So everybody is scared of pain.
We thought there is nothing much wrong. That is why we told.
When the
and everything.
But we already had MBS.
Yeah, that is obviously done in a local hospital. But we didn't do anything because we thought that it is insignificant. But the whole thing is like, that the child has noticed everything. Our conversation he has followed. He has seen what is dangerous sign, warning signs after a snake bite. And he was misleading his parents. And we asked subsequently to the parents, and he went to the toilet himself and took that. And this was immediately after the Holi. So
Basically, he had also confessed that he put some color which was left
So
during the Holi.
my summary will be that this child should be well taken care by the psychologists, the parents. He be a super intelligent child. The phobia is because maybe the school is boring for him. A very intelligent child will find the monotony. So this child should be.
No, he wanted some revenge again because some teacher told him something. So he was spreading this thing that there are snakes in the school, this school is a bad school, I will not go. So that was his
That was
entire
also
psychology. Subject changed me from this.
Because ma'am,
Right.
even a five-year-old boy, if malingering is reported, then this is a 9 years 2 months.
These children, like, they have the intellect to keep everything in mind, whatever history is being asked, then it's not so easy thing. It's quite a difficult thing to move around with the highest intelligence.
So that is to our surprise also, because that is why we actually gone for so many investigators to confirm, is that really a pigment or really a color which he had added. When microbiology told us this thing, then we went to the biochemistry. So what is the exact thing? Then when we found it was potassium permanganate, that was it.
So because if a snake bites and hells on the skin, that means lot of venom goes, and it's a very risky thing. Can't be like a snake is catching hold of the baby and the baby takes away. So those are the catch points which we have missed in this history.
Like a Hindi movie.
Maybe he saw somewhere and he
Next
just.
time when he comes for the follow-up, I think it will be an interesting point to ask the boy or the teacher or school. Man, how did this idea came to this child about the snake in the school? Man, has this happened earlier? Any episode in that school that somebody mentioned that the snakes are coming or this or that, you see? So the idea came to his mind, why not put all the blame, drama with the snake?
He has to write a note that the school is there dangerous because of snakes.
Oh, he wanted?
Oh, yes.
Oh my God.
The boy wants the
The
parents.
parents. That you write a note. that-
First time when they came.
Acha.
First time. they did.
What is the follow-up of the child?
Yes, that is
The child came for a follow-up. Child is fine, but I must say that I was so much surprised with the reaction of the child when we thought that this is probably fabricated, malignant.
Huh.
He was, if you see his reaction in front of his parents, we broke the news.
Yes.
And he was vehemently denying, no, I haven't done anything. And even the parents were also trusting him.
Naturally,
They're saying,
that is natural.
that is
Natural, obviously. You don't expect parents to
snake
go
bite
against the
is
child. you see.
happening.
Yeah, it is so difficult, for all of us pediatricians, where you say that it's a functional disorder, that the parents.
I agree.
It's very difficult for.
Very difficult for
That's
anybody.
what I mentioned to the proper counseling of both children and the parents. Both are.
Obviously, it has to be done that way. But interesting thing would be to find out whether such snake incidents has happened in the school earlier, and that's why that gave idea to this boy to feign about the snake. And how did the idea came to him? That would be interesting anyway. Interesting. Very good.
Our next presentation by Dr. Dipon, calcium in the time of corona.
Good afternoon, everyone. Today I am going to tell a tale about calcium in the time of corona. Myself, Dr. Dipan from CMRI. A 13-year-old boy presented with 2 days history of fever and persistent uncomfortable numbness, tingling and cramps. He has an average height, weight of 70 kg with BMI at 96th percentile. He had fever with no focus, but he was hemodynamically stable. But during our examination, a dramatic thing occurred. He suddenly developed severe persistent carpopedal spasm. So we immediately ordered urgent biochemistry and also fever screen. Initial report showed that his total serum calcium level was low, along with low magnesium level, high phosphorus level, normal creatinine level, and also parathyroid hormone level was higher. So the patient was promptly treated with injection calcium gluconate and injection magnesium sulfate, which controlled the tetanic spasms. Then supportive treatment for febrile illness were initiated. We also did an ABG, which ruled out alkalosis, and it also showed ionic calcium level to be very low. So our first thoughts are, it is a case of symptomatic severe hypocalcemia, mild hypomagnesemia, phosphate level relatively high, and parathyroid level high. During examination, 4th and 5th metacarpals appeared short. So can it be a case of pseudo-hypothyroidism, parathyroidism? So we ordered an X-ray. Now, as we can see, a line drawn over the head of 4th and 5th metacarpal is not intersecting the head of the 3rd metacarpal. It is going above the head. So metacarpal sign is absent in this child, and also no other phenotypical features were present. So we can rule out pseudo-hypoparathyroidism. Further investigation showed low vitamin D level. For fever screen, we did COVID-19 RT-PCR from nasopharyngeal swab, and it came out positive. Other fever screen reports were normal. Now, to find the etiology of hypocalcemia, we have to look at various interlinked lab parameters, and we see there are myriad of clinical conditions that can cause hypocalcemia. In our case, we have low serum magnesium level, elevated serum parathyroid hormone level, and low serum vitamin D level. We also have to keep in mind one important case cause of hypocalcemia can be sepsis. Now we did serial monitoring of all these lab parameters, and what we found is that after correction, serum calcium level increased from 4.7 to 8.4. Serum vitamin D level was also low. We give a loading dose of vitamin D, and vitamin D level was also normal. Parathyroid hormone level was initially high, but after correcting the calcium level, it decreased to near normal level. Serum magnesium level was also normal, also became normal. So our hyperparathyroidism was secondary to hypocalcemia, as parathyroid hormone level became decreased to near normal level after correcting calcium level. But the question still remains, what caused this sudden symptomatic hypocalcemia? Can it be due to low vitamin D only? But phosphate level was not low. Complete dietary analysis was done, and it ruled out long-term dietary calcium deficiency. Other findings were euthyroid, eucortisol, no calcification in CT brain, urine calcium creatinine clearance ratio was normal, and USG whole abdomen was also within normal limits. So can there be any association with COVID-19 infection? So we searched literature, and what we found that hypocalcemia is the second most common electrolyte abnormality after hyponatremia in COVID-19 infection. Even hypocalcemia has a clinically significant role as a predictor of disease severity, and it has a positive association with other inflammatory markers. Now, the cause of hypocalcemia in COVID-19 infection can be due to hypoparathyroidism. But our case, we found secondary hyperparathyroidism. Hypovitaminosis D is also another proposed etiology for hypocalcemia. The levels of various inflammatory markers were checked to see for any correlation, and some of the inflammatory markers level were found to be raised. But our patient had a hospital stay of 7 days without requirement of any intensive care support. Post-discharge follow-up for 6 months showed normal biochemical parameters. At 6 months of follow-up, he still continues on maintenance dose of calcium and vitamin D. Now, to summarize, severe symptomatic hypocalcemia or hypomagnesemia requires initial urgent correction. Subsequently, a stepwise approach is taken looking at the clinical phenotype, phosphate, magnesium, creatinine, vitamin D, and parathyroid level to determine the etiology of hypocalcemia. Hypocalcemia is reported to be the second commonest biochemical abnormality in COVID-19 infection. So, calcium level should be a part of the workup. And reports suggest that COVID-19 infection, low calcium level has prognostic significance, though our patient has an uneventful recovery. With this, I conclude my discussion. Thank you.
Just to say that Dr. Shiji Bhattacharya, consultant endocrinologist, is with us. He was also involved in the case. So, any pearls of wisdom?
Thank you very much. A very good afternoon to you all, and Dr. Moll as well. Well, I would approach the case in a little bit different way. First of all, when we look at the symptomatic presentation with obviously tetany, we went and looked back at the biochemical bone profile, and we find that the calcium is good. That's fine. But there, now we got to look at whether it's a vitamin D related or whether it's a PTH related. So if it's vitamin D related, we find both of those going in the same direction. Okay, so calcium low, vitamin D, calcium low, phosphate. Now, if we have a condition that we have a hypocalcemia with a phosphate which is out, so this is parathyroid hormone related. So if there's no other condition like renal failure, etc., now we are going to look at whether it's what sort of hypoparathyroidism it is, whether it's a functional hypoparathyroidism or there's anatomic defect. So obviously there's or genetic defect. So there's nothing, because the PTH levels are high, that rules out that any problems in the parathyroid gland itself. So obviously it's a functional hypoparathyroidism. And this functional hypoparathyroidism means it's a PTH resistance. So the PTH resistance can happen under few circumstances. One is a pseudo hypoparathyroidism, amongst them the three types, and the pseudo hypoparathyroidism. Now we go back and look at the clinical phenotype again. And if we find a short third and fourth metacarpal, then it's likely whether it's a pseudo hypoparathyroidism or not. Go and look back at a CT of the brain, whether there's calcification. And obviously, what's the difference? Difference is calcium and vitamin D replacement with 1-alpha D. Now, whether it's now differentiating pseudo hypoparathyroidism 1A, 1B, and 2. Now, if you have a skeletal defect, that means that what we classically call the AHO phenotype, Albright's hereditary osteodystrophy, short child, obese, short third and fourth metacarpal, and you have this sort of phenotype, then it's a pseudo hypoparathyroidism. And that's because of a genetic abnormality or query not known. If it is, but there the biochemistry is completely known. And you diagnose because of two things, because of the clinical phenotype along with basal ganglia calcification. Now differentiating type 1A, type 1B, and the 2. Now, if we have skeletal features similar to pseudo hypoparathyroidism, that is AHO phenotype, and we have the high PTH, then we label it as 1A. And this is because of a genetic defect or renal phosphate handling, and because of the parathyroid hormone, and this is due to gene acid. And the 1B is, again, you don't have the skeletal defect, but the same biochemical and other features. And that's again due to genetic abnormality. And the second variety is obviously where you don't have a skeletal defect and you have the cyclic MP responses there, and you can look into that. So rather than now, whether it's a combination defect now. So here you find the low vitamin D, so that's there. So the calcium should have gone down, phosphate should have gone down. So along with the low calcium, but the phosphate is still high. That means functional hypoparathyroidism is there. And now this functional hypoparathyroidism, magnesium deficiency is one of the common ones because it can cause to PTH resistance. Not only secretion, but also resistance. So we are looking at the resistance that can happen. So this is rather interesting. Now, considering its relationship with COVID-19, that's again very interesting.
You're making it complicated.
Just because in severe COVID-19 infection, severe hypocalcemia has been well documented and correlates with the severity of the infection and the prognosis as well. In mild COVID as well, it has been shown by Sanjay Vadada's group, the PGI group, that even in mild COVID, you can have a reduction in the calcium levels. And they have actually shown it's because of possible vitamin D resistance, possible PTH resistance. And some hypotheses are there because of the inflammatory markers, the IL-6 and the IL-1 beta, all those happen. Now, looking into that, when Sushmita told me that it's going to be presented, I was just flipping through that. She is always one of the most difficult person to explain. I was looking, and obviously there's a condition called FHH. That means familial hypocalciuric hypocalcemia, where you get a high PTH, but there the calcium is high. Okay, and you don't have a high calcium excretion in the urine. You have a low calcium excretion in the urine, and that's a diagnosis, a differential diagnosis of primary hyperparathyroidism. Now, that's because of an inactivating mutation of the calcium sensitive cells, and that's genetic. Now, if you look at hypocalcemia cases, there are quite a significant amount of case reports where they have found that 50% of patients who have hypocalcemia, and they have gone and looked back into it. There's 2 series I looked into it. They've actually done the genetic studies, and they found hypocalcemia with a relative hyperphosphatemia, and you find that there are genetic defects in the calcium sensitive cell, and that's activating mutation. And this COVID virus, because of this link to the attachment to the cellular surface and activating the various pathways, I don't know what's the relationship with that, but it can happen. So this is something new which I've learned.
So Shachit, just to come back to our case, the confusing thing with this case is in the condition you're talking about, where you have an inactivating mutation of a calcium sensing receptor, you should also have hypercalciuria, which we did not have last year.
No, you will have hypocalciuria.
No, the hypocalciuria is in the hypercalciuria.
Oh, right.
In the inactivity.
Yeah, inactivity.
So the problem with this child was that it was not fitting with any of these classes that we have very succinctly described. And I think the best explanation would be that there was a functional PTH resistance, which probably improved after the child recovered.
No.
So despite the PTH being high, the child persisted in having hypocalcemia. To some extent, vitamin D improved that, and with the improvement of the COVID symptoms, everything else actually fell into place. I think, the other issue is that the child improved just with calcium
and vitamin D.
and straightforward vitamin D, not activated vitamin D, just native vitamin D, which again goes against a congenital hypoparathyroid or pseudo.
Yeah, that's true.
I think let's have the judges make a few comments.
Yeah.
Oh, God.
Judges, 1 or 2 comments, then you have to make.
None from my side. No comment.
No, I want to
We have one question from chat box from Dr. Manish Shorkar. What were the skin lesions? Any explanation?
At presentation, there was acne from rash over the face, and with treatment, we applied
We
antibiotic.
did get the skin looked at, but it was just the impression was it was only acne and not anything related to the current condition.
Almost to the tune that when I had a look at the patient, I thought whether it's something like adenomostimation.
But also
And you know whether there were tumors in the brain.
which is one of the reasons for doing a CT scan also. Anything else, judges?
Just one thing I want to know, such low calcium in COVID, is it very well known? 4.6 is
And symptomatic in such a big
symptomatic.
It's been well documented. If the patients are unwell, sick,
But he
they
was
will
not
have.
unwell. He was not unwell.
Yeah, that's what I'm saying. But this has also been documented that vitamin D, in asymptomatic, mild symptomatic COVID, they have got vitamin D levels which are lower. They have got vitamin D resistance. They also have PTH resistance. And Sanjay Vadala's group, one of my juniors actually, he's the head in the department now. He did the phosphate studies and the cyclic MP as well. Not a huge lot of patients, it's only 20 odd patients. They looked at, that's one of those things. And I was accounting that what VD asked me. That how would they account for that? It's basically the activating nutrition along with the vitamin D deficiency. Because of the vitamin D deficiency, you are having a low phosphate excretion through the kidneys, and that's what I was accounting. Anyway, well, that's sometimes it happens. I think we must be. I must agree that we are all most of all labeled as idiopathic rather than idiopathic, and that's what we should.
Just one line, like this PTH resistant and COVID. So there must be a link. So can it be with any other virus?
Very interesting question. The link is not because of the virus per se. The link is because of the SARS, the systemic inflammatory response, and its cytokine response. And since COVID has the worst cytokine store out of all the out of most organisms.
So that's the question. In any cytokine release, we may get the similar.
Yeah, and possibly one of the reasons for critical care hypocalcemia, which is well documented for ages. I think partly it could be something of that sort.
Okay, thank you, sir.
I just want to, I remember sodium is there in the screening for COVID, but calcium is not there. So we should then add calcium.
That's right. Very good idea. We must add calcium now.
In the COVID screening.
Probably that's the whole idea of
that's the thing. That's right.
Any cytokine.
Last 2 years it has been going on. Nobody ever mentioned calcium.
Sodium is there. Sodium is there, but calcium is not.
Mentioned.
This is very surprising why people don't mention it.
It is the second most common electrolyte abnormality after hypertension.
But never mentioned
in adults.
In our discussion and everything, you see, never ever.
In adults, vitamin D supplementation in COVID patients is a routine. And these guys who actually based the first recommendation in adult guidelines, and it's people were giving. Knowing.
But there seems to be quite a lot of conflicting evidence.
That's there.
Sure. Let's get it.
Thank you, sir. Thank you.
Very good discussion.
So we have reached to our last presentation by Dr. Amulok. After all, what is the point?
Good afternoon, everyone. Myself, Dr. Amul Gopal. I'm DMB PGT, Department of Pediatrics at CMRI Hospital. Today, I'm going to present a case of, after all, what is the point, which tells about Master M, who is 4-month-old male child and resides at Kolkata. He is presented at CMRI Emergency Department with low to moderate grade intermittent fever for 3 days with intermittent inconsolable cry. And while crying, baby pulls up his knees with crying, and in between the episodes, baby was asymptomatic. And baby also had abdomen distension for 2 to 3 days with non-bilious and non-projectile vomiting for 2 days. And mother has also noticed that altered color stool, which is significant amount for 3 days. And there is no history of prelacteal feeds, and there is no rashes, and there is no history of cough, cold, or lethargy, and there is no bleeding from any other sides. This baby was born at full term by normal vaginal delivery. Birth weight was 2.9 kg, and baby was exclusively breastfed. And there is no significant history of, there is no family history significant, and past history is also not significant. On general examination, we found that baby's temperature was 99.5 Fahrenheit, and his pulse rate was 132 beats per minute, and BP was 84/66 mmHg. And there was no apparent dysmorphic features, and there was no pallor, no cyanosis, and baby was not ecteric. And his anthropometry measurements were age appropriate. On systemic examination, we found his CVS, CNS, and respiratory systems are within normal limits. On GIT, we found that baby had grossly distended abdomen, and on auscultation, his peristaltic sounds were absent, and there was no apparent organomegaly. On per-rectal examination, we found that rectum was empty, and on withdrawal of examination finger, there was significant amount of altar blood came out. On initial, this child was kept NBM and abdominal decompression was done and treated, managed with IV fluids and antibiotics and other supportive care. His blood sample and urine samples were sent and IV antibiotics were introduced as per the unit protocol. His initial investigation revealed hemoglobin was 11.2. His total counts were 4,400 and there is low platelet counts. Platelet counts were 1,24,000 and his CRP was raised and ESR was also raised. His electrolytes and renal function was normal and liver function was also normal, except there was a mild hypoalbuminemia, which was 2.8 gram per deciliter. His other fever profile, MP, MPDA, dengue, NS1, blood culture, and urine culture on subsequent days were no growth. Then we did X-ray, which shows grossly distended bowel loops with multiple fluid air levels, which suggestive of intestinal obstruction. Then we did ultrasonography of abdomen, which revealed ileocolic intussusception with mildly increased vascularity in terminal ileal mesentery and dilated small bowel and mild ascites. Here we can see compressed inner loops and edematous outer loops. Then child was reviewed by pediatric surgical team and open laparotomy was planned, and we found that there was a giant serosal hematoma which was acting as a lead point for intussusception, and a reduction was done under GA, and here we can see in picture there is a two giant serosal hematomas. And on postoperative day 2, this baby had persistent fever, continuous persistent fever spike for a total 6 days. Hence, we have upgraded antibiotics and relevant investigation were sent, which revealed hemoglobin is 10.1, total counts were 4,200, and his electrolytes and renal function was normal, and transaminase were raised, mildly raised, and albumin was 2.9 gram per deciliter. And other fever profile revealed dengue NS1, strep typhus IgM, S. typhi IgM, leptospira IgM, MPDA. All these reports were non-reactive, and ASO titer was less than 20 IU per deciliter. Hence, we sent further, as we have not found any conclusive reports for fever. So we did further investigation where we found nasopharyngeal swab for COVID RT-PCR was negative. His repeat blood culture and urine culture came no growth. Hence we sent SARS-CoV-2 IgG, which surprisingly came positive. Hence we did further inflammatory markers, which shows CRP 17.1, ESR, ferritin, procalcitonin, proBNP, and D-dimer all were raised, and his albumin level was 2.7 gram per deciliter. And his PT time was also raised, that was 16.2 seconds, and INR was 1.35. So we reviewed the WHO criteria for MIC in our child. We found all these 6 criteria were met in our case. So far we have got 4-month-old baby who is having abdominal distension with blood in stool, and he is suffering from ileocolic intussusception. And in open laparotomy, we found giant serosal hematomas, which were acting as a leading point for intussusception. And this baby had persistent fever spike for 6 days. Then we did further investigation where we found SARS-CoV-2 RT-PCR was negative, and his fever profile was negative. And his SARS-CoV-2 IgG was positive, and inflammatory markers were raised. So hence we are dealing with MISC. Then we did literature review whether does COVID-19 or MIC has previously been reported for intussusception. Then we did literature review. Then we found yes, in severe in COVID-19 can cause severe intussusception in infant, and there is another case. We found that spontaneous giant rectus sheath hematoma in patient with COVID-19. This case was reported. Then we had query whether there is still shedding of virus. Then we found another, then we found another study which revealed that 8 of 10 COVID-19 positive children had positive rectal swab even after the disappearance of the virus from the upper respiratory tract. Then with the special permission, we sent RT-PCR from the rectal swab and it came positive. So our provisional diagnosis is ileocolic intussusception due to giant serosal hematoma in 4-month-old infant with MIC along with positive SARS-CoV-2 IgG and positive rectal swab RT-PCR for SARS-CoV-2. On post-operative day 3, we started with IV methylprednisolone, and on post-op day 5, fever subsided and fits were started. And on post-op day 6, they started suspension prednisolone. And on post-op day 11, the full fits were established and IV antibiotics stopped. And on post-op day 12, baby was discharged home. So in GI symptoms of COVID-19 in children are more frequent and usually limited to the abdominal pain, diarrhea, and vomiting. Involvement of the gastrointestinal tract is related to the angiotensin II converting enzymes used by the virus to enter the cell, not only in the lungs tissue but also in GI tract, especially in the enterocytes. In our case, SARS-CoV-2 IgG was positive, and though his nasopharyngeal aspirate was negative, his rectal swab RT-PCR was positive for SARS-CoV-2, confirming rectal shedding of the virus. A giant serosal hematomas was acting as a leading point of acute ileocolic intussusception in the infant who had the features of MIC. So my take-home messages are SARS-CoV-2 viral shedding can persist for a long time, and GI manifestations are varied, and serosal hematoma so far was unknown complication of SARS-CoV-2 in MIC. As knowledge of this virus is still evolving, but it is certainly important to know that intussusception can be an unconventional manifestation of COVID-19. It is even more important to suspect intussusception when COVID-19 patient present with abdominal pain, vomiting, constipation, or blood in stool. This case was reported and it was published in Indian Journal of Pediatrics in April 2022. Thank you.
Thank you, Dr.
Questions from the judges?
Session is open for the questions.
Anyone else in the virtual audience also?
Just one thing, I think the history a little bit misguiding. You said in between the colic pain, the child was completely well, you said. But then you said abdominal distension was there. So I think there is little misguiding.
I suppose not misguided. I mean, that is, well, he meant that child is better.
The child was not toxic, sir.
No.
In between the episode, child was not toxic because of colic pain.
This is what he meant, really. Well means
trying to explain the nature of the pain.
And 4-month-old child, you see, well means when he is quiet and better, that is well. He didn't mean physically or.
Anyone in the family had COVID?
That's important.
No, ma'am. No.
And the cause of hematoma, is there a known cause of hematoma? Because the clotting profile, if I remember, was right. But clotting profile was not abnormal, was it?
PT was
1.35 is normal.
I know those hugely elevated. So whatever mesenteric thrombosis.
Oh my God, don't make it complicated.
No, but
my God.
I think that's right. I think
You are a very bad examiner.
Because 1.35 is not abnormal.
That's right.
1 point, your
Yeah,
6
abnormal. Never be abnormal.
is not abnormal. So the clotting profile was normal. So I'm saying
This is
he's
very
probably right, whether it was a.
But I think hematomas have been reported in MISC, right? You
Yes,
showed
yes,
that-
But mesenteric thrombosis will produce more symptoms, you see.
But,
And especially
Not
when
many have been reported. In adult literature, rectal sheath hematoma has been reported.
Sorry?
In adult literature, rectal sheath hematoma has been reported in 2 cases. Other than that.
But what is the cause of hematoma? That is number one.
That is the
Clotting profile normal.
Yeah, we are not sure. We have even the cases which are reported rectal sheath hematoma, they are also the clotting profile were absolutely normal. So whether there is any other causes like increased, I don't know. But as I said, this is not a very common manifestation.
Not at all.
Hematoma is not a very common association of. But these days, with so many cases of COVID, everything was related to that.
The word which I use nowadays with patient coming with many things, that COVID has been made a dustbin, you see. And whatever you can't explain, you put it in post-COVID. If you can find, the patient says, yes, I had COVID. So after 6 months, if he has grown the horns, it is post-COVID.
Sir, one thing is that during surgery, we observed that there is no vascular injury or no devasculation part. There is no devasculation.
For the examiner.
Yes, sir. No devasculation and all the vasculation of all the gut, the entire gut was normal. Only there is two serous hematoma near the lump of the just near the ileocecal junction, and we trained and they just put a needle and drained out all the blood. There is no serous injury. Only there is a hematoma, two hematoma.
So you put it some stain or something.
It was just fresh blood coming out from the hematoma.
Yes, sir. Yes, sir. I know. Only fresh blood come out. Nothing else.
So today is the functional day. Functional patient.
Was there any other reported case of COVID and interception?
Yeah, it's so bad. There were some reported cases.
Okay, so I think in the we will let the judges decide. If they go ahead. So we have a few cases for the audience, both physical and for the online audience. These are not for the judges. So in the discussion,
I'll be highlighting some interesting snippets which were spot diagnosed. So my first snippet 1. This was a child we encountered in our hospital, a 36-week male with respiratory distress, but the child, surprisingly, the child had absence of left nostril and ala. There was hypoplastic right nostril and bilateral choanal atresia. The child was ventilated here for long 14 days. The child had sepsis and was managed with IV antibiotics. Later, the child had was done tracheostomy, reconstruction of right nostril, and ET tube stent was given. Then the child started breathing spontaneously, and step-by-step tracheostomy closure and stent removal was done at the age of 2 months. So this is a case of choanal atresia with arrhythmia, and after that the child was followed up, and there was a herniation of brain matter at the left side. So reconstruction of the left side is planned later with neurosurgical opinion, and now the baby is currently in our follow-up, gaining weight and doing absolutely well. My next snippet 2.
Do you want to tell us about the diagnosis now or at the end?
No, the diagnosis is choanal atresia with arrhythmia. My next snippet involves this around 5 years old child presented with us with some of the listed features like coarse facial appearance and finger abnormalities like short fifth finger and toes with hypoplastic or absent nails. So from these clinical features, we thought that it might be a case of coffin series syndrome or fifth digit syndrome. And this coffin series syndrome is a very rare, and it has been reported fewer than 200 individuals with molecularly confirmed coffin series syndrome and had a pathogenic variant like ERID1A, ERID1B. And we did a genetic analysis, and we found that ERID2 pathogenic mutation was there. Thus, this was confirmed that it is a coffin series syndrome. 26. My next snippet 3. We encountered this child at our OPD, at our NICU with a 36-weeker male, and there was these skin manifestations, peeled skin over face and chest. There was multiple bullous lesion and gradual spontaneous bulla formation. Though the child has good tone and there was no active resuscitation was done, cried immediately and Abgar was normal. So from the clinical manifestations, this might be a case of epidermolysis bullosa. Epidermolysis bullosa in newborn is very rare.
again a very rare case, 1 in 50,000 to 5 lakh. And the main prong of management is pain management, prevention of sepsis, proper nutrition, skincare, especially with non-adhesive dressing is to be done. And the outcome is variable. And the final snippet 4, it involves, it involves a preterm child, a male preterm IVF child who presented with a respiratory distress syndrome, received surfactant. On day 2, had an acute kidney injury and peritoneal dialysis was done, and the child had necrotizing enterocolitis. On day 6, the child had absolutely grossly deranged coagulation profile, and we encountered these skin lesions, which was rapidly developing purpura. So from this clinical manifestation and these skin lesions, it can be concluded that this child has purpura fulminans. So again, it's a neonatal purpura fulminans is a rare and associated with GIC and perivascular hemorrhage. Gram-negative organism and staphylococcal sepsis are the most common cause of the acute infectious type. Idiopathic purpura fulminans follows a bacterial or viral illness and usually begins 7 to 10 days after the onset of the infection. And usually this purpura fulminans is associated with protein C mutations, inherited deficiency of proteinase or antithrombin 3 may lead to neonatal purpura fulminans. In our case, we got thrombophilia profile antithrombin 3 deficiency. And blood cultures, there was a Klebsiella species. That's all. Thank you.
All too rare things for me.
Thank you, Indrajit and everybody. Are the judges ready?
And one last thing, we wish everyone a very happy Diwali.
Thank you.
So I thank the judges, Dr. Priyamfal, Dr. Ashok Modi, Dr. Manjali Mishra, and our very own Dr. M.L. Mall for being here today. Obijita, if you would like to say a few words while the judges are adding up the marks. Obijita Achin. Any other comments from the audience who are online? Ready? So I will ask the judges to announce the first position.
Everybody has become very well. And we were all tight. Just because we have to give 2 papers, so that is the reason we have done.
This is the
final total.
Final total.
We decided or added all of the scores.
But naam ka bolta.
One
Team number is number 1.
Dr. Samanto.
So first place, Dr. Shamanto. Like to be These are just temporary certificates. The permanent certificate will come after the WBAP, after the CIP election. Congratulations, After. Second position is?
Second is number 6.
Dr. Gopal.
Congratulations, Amul. Then the rest of the presenters. Dr. Disha, come.
Everybody did well.
Very well. It was very difficult.
It was a difficult
choice.
Very difficult.
Dr. Omnigo.
Very difficult. All of you are as good as each
Very
other.
interesting cases. Very interesting.